Okay, today we're going to talk about atrial fibrillation, factors surrounding it, how we diagnose and treat, who we anticoagulate. So these are our objectives, understanding kind of the causes of atrial fibrillation, clinical manifestations, what it looks like on the monitor, which I know you guys all know from being ICU nurses or being nurses. Understanding who we anticoagulate, what we anticoagulate with, and when we need to refer to cardiology for further management. So, what is AFib? Again, it's characterized by an uncoordinated atrial activation with deterioration of the atrial mechanical function. So, again, we see this um, multiple areas of electrical impulse in the atrium that does not allow it for correct depolarization. AFib is the most common sustained cardiac arrhythmia. So obviously we see this a lot. It increases the risk of death, heart failure, hospitalization, and thromboembolic events. Again, irregular arrhythmia, no order of the contraction of the atria. Again, symptoms are usually due to loss of cardiac output, about 20%. So this is important in your patients with, especially younger patients, don't usually tolerate atrial fibrillation very well. They tend to have heart failure, chest pain, shortness of breath, so extreme fatigue. So a lot of times those patients need to have not only rate control, but then we need to look at trying to get them back into a normal rhythm. Again, just to review, atrial fibrillation on EKG. This is just a point that we make in every time we talk about arrhythmias is make sure you see it in two leads. And then classification of AFib. And this is important not only for you to understand for testing purposes, but also when you start to write notes for billing, classification of AFib. So paroxysmal atrial fibrillation, episodes of AFib that terminate spontaneously within 7 days. So these are patients that are in and out of AFib. You then have persistent atrial fibrillation, episodes of AFib lasting more than 7 days that may require either pharmacologic or electrical intervention to terminate. So are we cardioverting? Are we giving medications for that? Long-standing persistent atrial fib, so they're an atrial fib greater than 12 months. And then permanent AFib. So this is a fib greater than 12 months, but then also they've had either treatment failure or the decision has been made not to attempt to get them out of atrial fibrillation. These are some facts from an epidemiology standpoint. Again, you don't need to memorize facts for these epidemiology facts for testing purposes, just so you know, it affects a lot of people. It's worse when you get older. So those are important facts. The prevalence, as you can see, as you get older, goes up. Cardiac surgery is a risk factor. AFib is uncommon in childhood, except for congenital defects that are repaired after cardiac surgery. They can develop AFib. It's more prevalent in men than women, appears more in Caucasians than African Americans, and about 10 to 15% of the cases, the disease occurs in absence of comorbidities. So they don't have risk factors, but they do develop. AFib is associated with other cardiac diseases, which will go, or other comorbidity and diseases that we'll go into. So hypertension is a big one. Most common underlying chronic conditions with atrial fibrillation. Usually in chronic heart disease does not increase the risk factor, however, MI does. So atrial fibrillation occurs transiently in about 6 to 10% of the patients with an acute MI. The thought is that it's due to atrial ischemia or stretching secondary to heart failure. valvular disease, so almost any valvular lesion can cause issue, either stenosis or regurgitation with development of atrial fibrillation. So valvular heart disease is a big one. Heart failure, hypertrophic cardiomyopathy, which we talked about in a previous lecture, been reported about 10 to 28% in patients with hypertrophic cardiomyopathy will develop AFib. Congenital heart disease, about 20% of adults with an atrial septal defect. And then venous thrombotic disease, so people with DVT-PE increase the risk of having atrial fibrillation. Obstructive sleep apnea, definitely a big one. I would say probably 25% of referrals that I got when I was practicing in pulmonary for sleep were patients with new onset AFib for evaluation of obstructive sleep apnea. Obesity increases your risk. Diabetes increases your risk. Chronic kidney disease also increases your risk of atrial fibrillation. And then we have reversible triggers. So any type of surgery, especially cardiac surgery, usually they have better outcomes from the standpoint of it's usually transient in nature. Other reversible triggers, hyperthyroidism. We should always screen for hyperthyroidism in patients with new onset atrial fibrillation. And if we can, obviously treat that if it is come back, they have hyperthyroidism. Alcohol, so AFib occurs in about 60% of binge drinkers with or without underlying alcoholic cardiomyopathy. So if you have a patient that does drink quite a bit or binge drinks, you may need to counsel them on abstinence of alcohol to help decrease their risk of recurrent atrial fibrillation. Certain medications, theophylline, DIG, and then, obviously cocaine can increase your risk. Some other metabolic causes, carbon monoxide poisoning, hypoxia. That's where we see it a lot in critically ill patients. Hypokalemia, hypomagnesemia, hypercalcemia. So clinical manifestation, some people just have palpitations, weakness, pre-syncope feeling. And then you have patients that don't tolerate that 20% decrease in their EF. They develop decompensated heart failure, hypotension, syncope, angina symptoms. Again, there's a whole gamut from asymptomatic to patients that syncopize when they have it. Fatigue is probably the most common symptom that's reported. Like any patient, we evaluate, going to get your physical exam, assess for possible structural heart disease. When you look at listening to heart sounds, looking at jugular venous pressure assessment, do they have rales? Do they have edema? And then diagnostics, obviously starting with a EKG, are they in atrial fibrillation? If they're coming, this is more for outpatient management, but they're coming complaining of a lot of fatigue and palpitations, you want to make sure we ordered a 24-hour Holter. And if it doesn't show anything and they're still having symptomology, you're going to want to make sure that you order a longer Holter monitor. So we want to make sure that when we do look at EKG, are they in a controlled rate? Are they in uncontrolled rate? So if the rate's greater than 110, usually that's an uncontrolled atrial fibrillation. We usually would like the rates below 110. Resting heart rate would be ideal less than 80. You also want to make sure they're not having an acute MI. So a lot of times patients present with AFib with RVR. And when you're looking at EKG, you notice that they have ischemic changes in their EKG, sometimes are accompanied with a ST elevation MI or a new left bundle branch block. So you want to evaluate EKG not only for the rhythm, but if there's any other acute abnormalities noted. This is just showing atrial flutter. Diagnostics, so we're looking at laboratory studies. You want to do CBC, sometimes severe anemia that will trigger atrial fibrillation, electrolyte abnormalities. You're going to look at a troponin to make sure if there's any either elevation from demand ischemia, or they coming in with RVR and their troponin's elevating because of that stress on the heart versus are they having a non-ST elevation MI, which has now triggered atrial fibrillation. Looking at BNP to evaluate for heart failure, D-dimer looking at pulmonary embolism risk, thyroid studies like we talked about, looking at a DIG level if they're on DIG, toxicology if you're worried about overdose, alcohol levels if they're coming in intoxicated. Chest X-ray, we want to look at, is there underlying pulmonary disease that's causing this, COPD, pneumonia, do they have wide mediastinum, are we worried about aortic dissection that's triggered now their atrial fibrillation. Looking at echocardiogram, we're looking at a transthoracic echocardiogram for initial evaluation, looking at valvular structure, ventricular chamber, measuring systolic pressure, looking at ejection fraction, and then TEE a little bit are about to evaluate left atrial thrombus, especially if we're looking at cardioversion. And these are two videos for you to look at. It's part 1 and 2, quick 10 simple rules when looking at echocardiogram for a patient with atrial fibrillation and the importance of getting an echocardiogram. Now we're going to talk about rate versus rhythm control, theoretical benefits of rhythm control, improved hemodynamics. You're going to get that 20% ejection fraction back, symptom relief, improve exercise tolerance, avoid risk of stroke, avoid anticoagulants after you've been in a regular rhythm for 3 months. This is a comparative study done in 2002, the AFFIRM trial looking at 5-year outcomes for rhythm versus rate control. Take home point, no difference in death, stroke, major bleeding, cardiac arrest in either group. So rhythm versus rate, same 5-year survival, so no big deal or no benefit from either one. However, you need to look at your patient to decide, is rhythm or rate control more beneficial? If you have a patient that has refractory heart failure because of atrial fibrillation and needs that 20% ejection fraction, then we're going to look at rhythm control. If it's someone who's tolerating atrial fibrillation that has no significant risk factors for major bleeding, then rate control and anticoagulation are the way to go. So again, this is a summary. The AFFIRM trial showed no advantage for rhythm control. Rhythm control is needs to be evaluated on a patient-by-patient basis. Both groups had similar stroke risk. Another take-home, torsades, bradycardia are more common in the rhythm control patient, and they were more likely to be hospitalized due to adverse drug events. So again, when we look at comparison trials, why haven't there been other ones? Medications used to maintain sinus rhythm have proarrhythmia and other toxicities. So we're not seeing a lot from the AFFIRM trial that are looking at pharmacologic rhythm control or cardioversion. We're looking at, there are some new studies that show that catheter ablation may be the way to go if possible. That will decrease the reoccurrence of patients coming in with heart failure and things. So approach to selected drug therapy for ventricular rate control. When we talk about rate control, if they have no significant cardiovascular disease, then first line medication beta blocker, then looking at calcium channel blocker with cardizem. If they're refractory or having significant hemodynamic compromise, looking at amiodarone, but understanding that that may convert the patient. If the patient has hypertension with a preserved ejection fraction, same medication route, beta blocker first, calcium channel blocker. Now, this is where I see a lot of providers that don't necessarily assess that previous history and what the patient's ejection fraction is. If they have significant left ventricular dysfunction and heart failure with the decreased ejection fraction, you want to stay away from calcium channel blockers because it could really cause hypotension, worsening heart failure, and additional decompensation. So you want to go with beta blocker, the refractory digoxin, and then moving to amiodarone. For patients with COPD, beta blocker is indicated. There's been multiple studies that show there's no significant risk of um, bronchospasm from beta blocker therapy, so you could go ahead and utilize those. So in 2014, these new guidelines were released. There's a 2019 update, which I incorporated into the lecture that we'll go over. This is looking at the more comprehensive CHAD2 score, so the CHAD2 DS2 VAS score for evaluation of patients who need anticoagulation. This is the CHAD2. And I'm not going to ask you to calculate it. I need you to remember, though, in either scale, if the patient has a CHAD2 score greater than 2, anticoagulation is indicated. The current guidelines in 2019 have been updated that we should be utilizing our direct oral anticoagulants, our NOACs or DOACs for patients if there's no contraindication and they don't have significant mitral valve regurgitation. If the patient has a CHAD2 score of 0 to 1, then we can utilize aspirin if there are some risk factors. If they have a CHAD score of 0 and there's no significant risk factors, then they don't need to have any anticoagulation. Again, this is just talking about the updated scoring system. So this is just an overview of it, and you could, in your MedCalc, I'm sure there's a section for this that you can just plug it in, and you should be documenting this on any patient you admit with new onset atrial fibrillation. Stroke risk and scoring. This is something that you can talk to your patients about, especially when you talk to them about the need for anticoagulation. If they have an elevated score, the more likely they are to have associated stroke. So they need to understand that there's a risk benefit from anticoagulation. This is just a slide showing that they've added all the oral direct anticoagulants as recommendations. This is the recommendation now that if the patient has moderate to severe mitral stenosis, I think I said regurg earlier, I apologize, or a mechanical heart valve, they should be utilizing warfarin. If they do not have those risk factors, then a NOAC should be, oral anticoagulant should be utilized first. And then if you are using warfarin, 2 to 3, an INR of 2 to 3 is what is recommended. If they have a mechanical valve, that will be 2.5 to 3.5. This is also talking about the evidence that indicates aspirin use is a mean of lowering stroke in patients that have a score of 0 to 1. If it is higher, the use of aspirin is not going to be enough for that. And radiofrequency catheter ablation should be used as initial treatment if patients have recurrent symptoms of paroxysmal atrial fib. So they should be evaluated for electrophysiology study if we are concerned that their symptoms are paroxysmal atrial fibrillation and they have decompensation every time they have a fib. Again, this is just another summary on the management. This is looking at the different oral anticoagulants. They all come with risks. These are all in the drug profile. So again, these are first-line agents. And this is a slide talking about that they have put in recommendations if the patient does have life-threatening bleeding on these oral anticoagulants that we should be utilizing the antidotes. And then for patients with talking about the anticoagulant regimens, balancing risk and benefit, that we should, all patients with A-flutter and AFib are just as likely of developing stroke, so that we should be utilizing the same risk profile for each. And then when we talk about management, again, the cornerstone of management are rate control and anticoagulation. So if the decision is that we are going to not try to chemically cardiovert the patient or do electrocatheter ablation, it is rate control. Rate control has shown to have improved degrees of symptoms. And when we look at what is rate control, so most patients, a heart rate less than 100, less than 80 beats per minute at rest, less than 110 during exercise. We talked about what are the drug regimens. First line should be beta blocker therapy, second line calcium channel blocker, unless they have a reduced ejection fraction. Then we should utilize digoxin. It's not first line agent in AFib unless you have a decreased and can't tolerate beta blocker and you have a decreased ejection fraction. Rate control, again, IV beta blocker, IV calcium channel blocker. Watch with patients with low EF, can cause hemodynamic instability. Consider IV amiodarone for rate control if patients, if you have conditions that the patient can't utilize a beta blocker or calcium channel blocker. This is especially important in the post-op cardiovascular surgery realm. Many times we use IV amiodarone. Rate control, and with the rate control, we'll convert the patient. Doesn't mean they need to be on long-term amiodarone. A lot of times one dose can help with that, with rate and conversion. So the important thing with IV amiodarone that you understand is that we may convert those patients into a normal sinus. And if they've been in atrial fibrillation greater than 48 hours, there is risk of stroke. So we need to be, or if we don't know if they've been in AFib, we need to monitor for signs of stroke, especially if they've not had TEE. And then rhythm control, how are we're going to pharmacologically cardiovert them. So list of medications that we can use. Many of these are proarrhythmic. They prolong QT interval. So you need to be careful when titrating these medications, watching for prolonged QT and ventricular dysrhythmias. This is just talking about for patients in AFib or A-flutter for greater than 48-hour duration, or if they have not had or don't know when their AFib has initiated, that you need to anticoagulate with warfarin or a oral anticoagulant for at least 3 to 4 weeks, or patient needs to have TEE prior to cardioversion. So long-term management atrial fibrillation, again, you're going to look at your patient. What are the risk benefits of rate control versus chemical or cardioversion, and the risk of bleeding. So again, when we look at risk of bleeding, we look at age. Do they have any underlying liver disease, malignancy? We're going to treat those patients with low molecular weight heparin, Lovenox, especially if they're undergoing treatment. Does the patient have any other risk of prior stroke? Have they had a history of liver failure with an elevated INR? What's their nutritional status? All those things we need to look at when we talk about risk benefit of that. Non-pharmacological management, so catheter ablation. There's a slide on this in a little bit that is a good alternative for patients that have persistent symptomatic atrial fibrillation. And again, the new evidence was included in this 2019 update on improved mortality rate, has been published with patients with AFib that had a catheter ablation compared to patients with medical therapy. So patients should be evaluated by electrophysiology. This is just showing, where we go the lumen of the pulmonary vein, and they ablate the small vessels around that to decrease the area with excitability that causes that abnormal depolarization of the atrium. So prognosis, AFib 1.9 or 1.5 to 1.9 higher risk of death associated with increased morbidity and mortality, especially due to stroke. So it's important that we intervene, we document appropriately, we risk stratify the patient for anticoagulation and rate control or anticoagulation and rhythm control, and that they get adequate referral to cardiology for evaluation for possible need for electrophysiology intervention. Some references. If you have any questions, please let me know.